This is the first part in a series on the MRI appearance of arachnoiditis. What we're going to be looking at are the various MRI appearances of arachnoiditis, but we're also going to look at the pathogenesis, which is important to know. Arachnoiditis is not that uncommon. We sort of think of it only in terms of infection, but it's relatively common post-op spines. There's a lot of post-op spines that we image. So it's an important condition to be able to understand and recognize. So we're going to run a series on the imaging appearance of arachnoiditis. And this first, we're going to look at probably what's the most important thing, and that is actually the normal distribution of nerve roots. What do they look like? How should they appear? And if you don't know this, then it's very hard to actually look at pathological findings in arachnoiditis because knowing the normal is so important. So in this section of the series, we're going to look at the normal appearance of nerve roots in the lumbar spine, and we will also look at the pathogen of arachnoiditis and why does it occur, what exactly happens. If you understand that, then the imaging appearance becomes a lot easier to understand and to recognize. So let's start. We're going to go with part one. We're going to look at the imaging appearance of arachnoiditis. And what we'll cover is that we'll look at the pathogenesis of arachnoiditis, what the normal nerve roots look like, because normal is always the most important thing. If you don't know that, you can't work out what abnormal is. And then we're going to look at the effect of arachnoiditis on nerve roots. There are changes depending on whether it's an acute arachnoiditis or the more chronic appearances. And some of the things that we often don't sort of think about are the changes in the subarachnoid space and also the effect that arachnoiditis can have on the cord, and a couple of really late chronic changes, which are pretty uncommon. So what's arachnoiditis? Arachnoiditis is basically inflammation of the arachnoid membrane. And the arachnoid membrane consists of the dura, arachnoid, and pia. And I think this bit is important. It's important to know that these are not vascularized because that comes into effect when we're looking at contrast, when we give contrast. What happens with arachnoiditis is that there is an acute inflammation or infection or haemorrhage, and that results in fibrin and an exudate being deposited on the nerve root sheaths and the arachnoid. The effect of that is that eventually you start to get collagen formation on it. The nerve roots start to stick together. You can also get similar changes where you get collagen within the subarachnoid space and you end up forming septa within the subarachnoid space. The most common cause, I think, now would be post-operative or infection, depending on where you live. For us, it's probably most commonly would be post-operative changes, but in other countries, infection would certainly be a common cause of arachnoiditis. In the lumbar area, it's reported up to about 20% of post-laminectomies or fusions will have some form of arachnoiditis. It's actually quite common to get changes of radiculitis or some early septa formation post-operatively. A lot of people will get it, but it doesn't persist. The ones that persist can be up to about 20%. And I think the other thing that's important to know, so we think that the surgery needs to be through the dural space for there to be arachnoiditis, but even extradural surgery can result in arachnoiditis because it apparently results in changes in vascularity. So it can cause a radiculitis, cause an arachnoiditis, even if you're operating in the extradural space. So we've got lots of other causes of trauma, hemorrhage. If we inject things and when a spinal tap or puncture, if we're injecting things into the subarachnoid space. We're not specifically going to talk about malignant arachnoiditis because it's not strictly an arachnoiditis. It's basically this is tumor cells lining the arachnoid. So it's not an inflammatory or an infective arachnoiditis. Okay, so let's start with normal. And the normal distribution of nerve roots is important because arachnoiditis in the lumbar spine affects the distribution of nerve roots. There's the term cauda equinus. It's like the tail of a horse. So if we look at proximally where the conus is, the nerve roots are all centered close to each other and they're bunched together. As you go out more distally, the nerve roots start to separate out. So that's the cauda equina. That's the appearance that we're expecting to see in the lumbar spine. So depending on which level you are scanning at, you will have different appearance of nerve root distribution. So if we're up at that conus level, so here's the conus in the center of that blue circle, we have nerve roots that are distributed around that conus and they're very close to each other. When you get to the mid-lumbar level, so around L3 or so, you see that the nerve roots start to separate. So they're starting to become further away from each other. And when you get to that S1 level, they are really separated out and they're basically distributed around the margin of the spinal canal. So to see this appearance down at the S1 level would be abnormal. also to see this appearance at the S1 level would be abnormal. So it's important to know what the appearance of a normal nerve root distribution is at these levels. And when you're looking at a scan, does it fit? Am I at the S1 level? Do I have a nice distribution of nerve roots like this, or do they look like they're bunched up together? Because if it's bunched up like this, it's definitely abnormal. The other thing is on the sagittal scans, you should see the sort of fanning of the nerve roots. So basically, if we go back to that cauda equina appearance, the horse's tail, it just sort of fans out. So this is what we see on a sagittal scan. We see the sort of distribution of nerve roots as they're coming out into the foramen. As a rule, this is not as helpful. The axial scans are going to be more helpful to you. Okay, so let's look at a case first. So we'll just go through normal to begin with. Let's go to the axial scans. Let's start superiorly. So we're not at the level of the conus, we're just below the level of the conus, but you can see that the nerve roots proximally are starting to separate. They're not really close, but they're sort of separating out, but they're still relatively together. As you start to come down, you can see that how they separate out. So they start to go more posteriorly and they start to go more peripherally. And when we get to the level of S1, the nerve roots are really peripheral. Now, the important thing is that, again, when we come to abnormal in a moment, it's important to know this appearance. Yes, the nerve roots here are peripheral, but they're not stuck up against the dura. So here's the edge of the thecal sac, and you can see that there's some CSF between the nerve root and the thecal sac. There is some separation. They're right up against the edge of the thecal sac, but there is some separation from the thecal sac. And to see more of these educational posts, we have a WhatsApp community channel which you can join. And at the moment, we also have 10 specific courses on joints and spine that you can learn in much more detail. And if you just want to continue seeing more of these videos, you can also subscribe to our YouTube channel.